Welcome to our meeting. I am Amy Gutmann. I am president of the University of Pennsylvania, and I also have the privilege of being chair of the Presidential Commission for the Study of Bioethical Issues. Our vice chair, Jim Wagner, is unable to join us today, but he sends his regrets, and he will be following our deliberations and be well briefed. On both of our behalves, I welcome you to our 22nd meeting, which is for us quite staggering. It seems that time has gone by very quickly. Let me begin by noting the presence of our designated federal official, Bioethics Commission Executive Director, Lisa M. Lee. Lisa, please stand up. Lisa makes this meeting official, so thank you for that and for everything else you do for the Commission. I'd also like to ask the Bioethics Commission members to introduce themselves. Let's begin with Nelson.
I'm Nelson Michael. I'm a research physician at the Walter Reed Army Institute of Research.
He keeps us in line.
Hi, I'm Anita Allen. I'm the Vice Provost for Faculty at the University of Pennsylvania, as well as Professor of Law and Philosophy.
I'm Raju Kuchalapati. I'm a professor of genetics and medicine at Harvard Medical School.
Hi, I'm Christine Grady. I'm the chair of the Department of Bioethics at the NIH Clinical Center.
Dan Solmacy, the University of Chicago, Department of Medicine and Divinity School.
Hi, Barbara Atkinson, Planning Dean for the New Medical School at University of Nevada, Las Vegas.
Steve Hauser, Chairman of the Department of Neurology at the University of California, San Francisco.
And we also have Nita Farhani on the phone, who's joining us from Duke. Nita, can you introduce yourself?
Yes, good morning. Nita Farahani, Professor of Law and Philosophy and Director of Duke Science and Society at Duke University.
Thank you. During this meeting, we're going to continue our work on education and deliberation. We're going to be deliberating about deliberation, which is what we normally do deliberation, but today we will be deliberating about it, and also about bioethics education. And before we begin, I want to take just a moment to explain how we take public comments. There are comment cards. There are at the registration desk, but also every staff member has them. We really welcome your questions or comments. And staff members, can you hold them up, your cards? Just ask a staff member for a card. Write down your question. Lisa or Michelle or one of our staff members will pass them up to me, and time permitting, and there usually is time, we will take the questions. If we can't take your questions here, we get back to you after the meeting. But I really encourage people to write down questions. To begin this morning, we're going to begin for about a half an hour to give our working group reports, our considerations about the intersection between deliberation and bioethics education, why deliberation is so important for education, and education is so essential to further deliberation. And what I'd like to do is frame our discussion with just some examples of deliberation and its impact in action as we have experienced it on the Commission. Enough time has now passed to see some of our own deliberations and the resulting recommendations that have directly implemented the results of those deliberations. So there are some people, some critics of deliberation, I don't know where they are, but they're there. And we should pose the criticism ourselves as that question, well, it's very good in theory, but does it have any effect in practice, especially in a time which is characterized by a lot of what's been called soundbite democracy. But we have found actually, and the Commission is set up in a way that's conducive to this, that many of our deliberations have actually found their way into practice at a time when people have been clamoring to see some things actually happen in the public realm. These haven't changed the global economy. Nothing has, to my, that has been the result of deliberation. That's too much to expect, but they have made a significant difference. So let me give some examples. I'll begin with the most challenging report we had to do by a long shot, and we were charged to do this report, and we called the report Safeguarding Children. And in it, we recommended, after considerable deliberation, hearing many different points of view within communities and between communities. So we heard directly contradictory points of view in the pediatric medical community, for example. We deliberated. It was, as all of our deliberations, public. We got a lot of public comment. And we recommended that research for pre-event pediatric medical countermeasures. In other words, let me just put that simply. We recommended that research for the safety of vaccines for an event that hadn't happened yet, like an anthrax attack, research on children, proceed via progressive age de-escalation wherever possible. And that we recommended that because the research that had been done on adults, which is always the first place research for these vaccines is done, couldn't tell us that doing research on children for these vaccines would be safe, would meet the safety standards. So we recommended that you begin with the oldest group after you look at the youngest group of adults and see that that was safe, and you do progressive age de-escalation research. In an effort to begin to implement our suggested research design in anthrax vaccine absorbed, AVA it's called, the Biomedical Advanced Research and Development Authority and the Centers for Disease Control and Prevention, CDC, recently published a study reviewing existing data and comparing the effects of AVA on 2 young adult age groups, which is precisely what we recommended. The study found that AVA's safety and immunogenicity were similar among the 2 compared age groups, that is 18 to 20-year-olds and 21 to 29-year-olds had similar safety. And that set the stage in turn for informed age de-escalation with pediatric patients. So they have done precisely what we recommended, and that was not the pre-existing recommendation. And there's been really widespread affirmation that this is the right way to do things. And so I think in a report that we deliberated about, and I would say in common language, we agonized over publicly. We came out, and we all felt good about where we came out. We actually think it's a big step forward that the agencies in charge of this have taken our recommendations and moving it forward. In an area that is second to none in being controversial in this country, which is vaccine research. Second example, I'm just going to give a few examples. Incidental findings, our work there has also made a mark. So let me give you the backdrop to this. In March 2013, the American College of Medical Genetics and Genomics, ACMG, I've learned every 3- and 4-letter combination that I thought I could keep in my head here. The ACMG announced recommendations for disclosing incidental findings in clinically indicated whole genome sequencing. And after extensive debate over the right of patients to opt out of certain genetic analysis, ACMG concluded, and I quote, that these findings be reported without seeking preferences from the patient and family and without limitation due to the patient's age. So they reported against getting any kind of consent. This conclusion stood in stark contrast to one of our recommendations in our report, which we called Anticipate and Communicate. Our report came out later, and after our report's publication, ACMG updated their original recommendations. They actually changed, modified in an important way, and I quote, this is what they now state and recommend, and they have a very good record of their recommendations being put into practice. Patients should be informed during the consent process that if desired, they may opt out of such analysis. However, they should also be made aware at the time of the ramifications of doing so, completely consistent with our recommendations. In addition, ACMG followed the Bioethics Commission in adopting the term secondary findings, specifically attributing that decision to our report, that people should be aware of secondary findings, which is a better term than incidental. Finally, I'll offer a recent example from abroad, since one of the characteristics of this commission, of which we've benefited and of which we're proud, is that we have reached out internationally. The report we did on Guatemala, we put together an international panel, and in all of our reports, we've asked for the incredible expertise that you can find now internationally in bioethics. And that's been welcomed by our colleagues, internationally, but it's also, or I should say, and it's also really strengthened our own deliberations. So here's a recent example from abroad. Starting in the mid-2010s, amid a growing body of research on mitochondrial disorders and therapies, public interest in mitochondrial donation became a topic of great public interest in the United Kingdom. In February 2011, the UK Secretary of Health requested that the Human Fertilization and Embryology Authority, HFEA, so I don't have to say the whole thing over and over again, more thoroughly explore, and I quote, expert views on the effectiveness and safety of mitochondrial transfer. Upon completing a comprehensive scientific analysis, HFEA acknowledged the need for an analysis of the ethical issues. In September 2011, the Nuffield Council on Bioethics, of which we feel particularly close and we admire greatly, established a working group to oversee the project. The Nuffield Council subsequently published a report in which, among other things, it encouraged broader public deliberation and strict parliamentary oversight. HFEA then partnered with ScienceWise, the UK's national centre for public dialogue and policy making involving science and technology issues, which we'll hear more about later today. So ScienceWise was partnered with HFEA to create a public process that included the use of deliberative workshops, public representative surveys and questionnaires, open consultation meetings, and patient focus group, a really thorough deliberation. And the findings found broad public support for the use of mitochondrial donation techniques. Following these processes of public deliberation, the House of Commons and the House of Lords approved regulations on mitochondrial donation in 2015. The United Kingdom is the first country in the world to approve a regulated system for the use of mitochondrial donation. That is something that we, as a deliberative commission, really admire and applaud. It was really a model of putting public deliberation into practice.